As you know, there's a lot of controversy with screening men for prostate cancer. Who's the appropriate man to be screened? How should he be screened? How should he be biopsied? And the exciting thing is there's a lot of work going on how to make that process smarter and better, so that men who do undergo a biopsy, it's more likely to find a clinically meaningful cancer, and on the other side, more men can avoid a biopsy if the biopsy does not have a lot of value. So there's a lot of different strategies that were presented to try to improve upon our current standard of care. One of those strategies is to identify a PSA level at a relatively young age, and based on that level, can tell a man come back in 2 years, in 5 years, or in 10 years, very similar to how people do with colonoscopy based on your initial colonoscopy, and the data was very encouraging. Another one is to look at a man's genetic makeup, either through a cheek swab or through a blood test, and that genetic makeup can alter his risk and help us make smarter decisions and give better advice. Most people don't realize that a man's PSA level can be corrected based on his genetic profile. So there's some exciting data to suggest that we should take the PSA level, combine it with the genetic data, and the corrected PSA becomes a lot more accurate. And additionally, there was some data presented on urine-based genetic tests that improve upon just PSA alone or other strategies in order to decide who should have a biopsy or not. And then lastly, there was some exciting data on when a man has a biopsy. Incorporating MRI is a smarter strategy where they better target meaningful cancers. In other words, the yield of the biopsy is better, and importantly, with use of the MRI, there's fewer biopsies needed and fewer men that might